Here is Dr. Michael Crow answering the question, what kind of glaucoma do I have?
Well, thank you, everybody, and I'm sorry I messed up your schedule a little bit, but I think now we're back on track. And this is a question I get asked many times every day. What kind of glaucoma do I have? And, you know, in some senses, my talk is going to be a little more of a general overview than Dr. Freudenberg's, as I'm going to have to cover various topics and give you a bit of a sense of the various types of glaucoma, and maybe that will help you when you go to your doctor's office to understand why you're being treated in a specific way. You know, first it's nice to step back and even wonder, you know, what exactly is glaucoma? And that's also a valid question. It's not always clear exactly what we're talking about when we say, well, you have glaucoma. And before it used to be easy. Say 30 years ago we'd say, well, glaucoma is elevated intraocular pressure that's higher than normal, with optic nerve damage and visual field loss. Well, now we understand that glaucoma can occur even at normal pressures in some folks. We also understand that people can have glaucoma before they have detectable visual field loss. Just like Dr. Freudenberg just showed, we're now starting to see changes to the optic nerve before we see the visual field damage. So it might be more accurate nowadays to talk about glaucoma, as Dr. Shields and Spaeth did in a recent article, stating that glaucoma is a characteristic optic neuropathy which derives from multiple stages and various risk factors, of which an IOP too high for that particular patient is a major factor. So backing up a little further, you know, this is a model of the eye. We've all seen this. And really the part that we're sort of concerning ourselves with, obviously, is the optic nerve in the back of the eye. That's the structure that gets damaged by glaucoma. More particularly, we're talking about the nerve here again, and it's right in the back of the eye. Obviously, the information being absorbed by the retina is transmitted through the optic nerve and to the brain. But what is the optic nerve really? It's really a bundle of these little nerve axons. Those are called ganglion cells, retinal ganglion cells. So think of the nerve as this bundle of all these ganglion cells that spread out on the back of the eye. They really comprise the whole retina. And you can see in this cartoon all these very fine little lines, and those are the ganglion cells. So glaucoma really is damage specific to the ganglion cells, and that causes visual field loss. And as you can see in this model, each little tiny ganglion cell serves a specific portion of the retina. And if you lose, say, a bundle of ganglion cells, you'll lose a portion of your vision that's served by that area. Let me show you how that looks. So here's glaucoma. Glaucoma is the loss of retinal ganglion cells. And here's an example on just sort of color fundus photography of what that can look like. There's this sort of dark band between these two areas. That's an area where those little tiny nerve axons, that little bundle of tiny nerve sort of cells, has been damaged. So again, the optic nerve is this bundle of cells, much as if you've ever seen a cable at your house, the cable TV. If you open it up and it has all those tiny little copper cables inside, the optic nerve is kind of like that. It's like this sort of bundle of tiny little cables. So this is a sort of a wedge of tiny little cables that's been damaged through this process that we are elaborating. Here's how it may look on what we call red-free photography. And you can see this area, this wedge of these ganglion cells that have been lost due to this process of glaucoma. Here's a wide wedge down here. Here's a smaller wedge up there. And there is going to be corresponding visual field loss when you have a wedge of ganglion cells that are damaged. So a healthy nerve looks like this. It's basically a healthy-looking, what we call the disc. It's pink and intact and full-appearing, whereas a nerve with glaucoma does not look like that. This is why we examine the nerve so carefully. We're trying to see if there's changes to your optic nerve. And as you can see here, this nerve does look different from this one. In this nerve to the right, there's this little wedge, this little sort of notch, what we call this focal loss of the normal rim, right down here. You can imagine that that's an area where all those ganglion cells would be damaged or lost. And there's going to be a corresponding visual field defect like this. So here's an example of a visual field defect that's typical in glaucoma, and that's that test we do and that many patients find, you know, fairly annoying because it is a little bit of a tedious test. You know, it can look sort of like this depending on the printout, but what it's really telling us is that there's damage to the nerve and that there's some functional loss. So again, that structure and function that Dr. Freudenberg told you about. So here's a sort of a static example of a patient that I saw, I think, yesterday. And here's an example of a patient that's having change over time. Initially, there's a smaller area of damage, and then over time, visit to visit, it's getting worse. So what we're trying to do is prevent that worsening, and that's what we're doing when we treat glaucoma. Okay, so what are some of the risk factors to develop glaucoma? And I'm doing all this background, and then I will get into the types of glaucoma. It's important to understand why we're even doing and what's happening. So what are the risk factors? Well, we know from various major government-sponsored studies that there are different risk factors for glaucoma, and some of which have come up, such as age older than 40, a family history has been shown, intraocular pressure, and that I'll get to in a little bit more. So all these major studies, they help us determine what we're doing is right or not. In fact, there is even some question, you wouldn't maybe believe it, but back in the 80s there was a question about whether treating the intraocular pressure was of any validity. There were some folks that were looking at the literature and saying that wasn't supported. So these major studies came along and have really proven that, yes, treating the intraocular pressure is the most important thing we can do to prevent the progression of glaucoma. Other risk factors have come up in other studies. They seem to show up in some and not in others. There's some thought and talk about dietary concerns, although that's really not been really fleshed out. Perhaps being obese is a risk factor. Myopia has been listed as a risk factor. That means being nearsighted. Folks that may have migraines or hypertension or diabetes, they may be at more risk to develop glaucoma. So there's things that people can do on their own that may lessen the risk of glaucoma, such as taking care of their high blood pressure, making sure their blood sugar is under good control. But of all these things, from the standpoint of the doctor, intraocular pressure is the single most important modifiable glaucoma risk factor. So the treatment of high intraocular pressure, as you all know, includes drops, may include lasers, and may include surgery. Now let's get to what really differentiates the types of glaucoma. And to do that, we have to sort of step back and look inside the eye. And there's a structure inside the eye called the angle. And you may hear us talking about the angle at times in your office visit. You may have heard that mention, a narrow angle or an open angle, and that's really what I'm getting at in the types of glaucoma, because this is really where it's critically differentiated between an open angle and a narrow angle. To do that, we have to look at the inside of the eye. We have a special prism, I have a slide next that shows what it looks like, that looks at the inside of the eye, looks at this angle structure. So looking from the inside of the eye, between the iris down here and the cornea, imagine yourself being shrunk to the size of this little person and looking on the inside of the eye, you can see the drainage apparatus in the eye. And this shows you what it would look like when it's normally open, and that's all the way to the left here. I think my arrow should be showing that. Yes, it is. So over here, this sort of pigmented band, this top sort of pigmented band, this evenly pigmented band, that is called the trabecular meshwork, and that is the drain of the eye. And if you can see that, if the doctor can see that on examination, it means you have an open angle, okay? So that's where the fluid is being produced in the eye constantly, all the time, 24/7. That's where that fluid is slowly being drained. More fluid is being made, so does this dynamic process. As we go along here, you can see what the angle looks like to the examiner as the eye, as it's looking more narrow and difficult to see. Here, this trabecular meshwork is just visible, although still you would expect that fluid could get access to it. But over here, if you look all the way at the right, now the trabecular meshwork is blocked. What's it blocked by? It's blocked by the iris. So in this person, in this example over to the right, this will be a person in whom the iris is coming up really far forward and blocking that drain. Okay? So that would be sort of considered a closed angle. And I'll show you a few more slides of that because it's not always clear. So this is a cartoon of the angle, sort of a cutaway from the side. Again, here's the eyeball. We're sort of looking at this one little wedge of the eyeball, and it's right here. This is the iris. That's the colored part of your eye. This is the cornea. That's the clear sort of window into the eye. And the drain is located right here. Here's this trabecular meshwork area. And what's that lead to? Well, that leads to various collector channels that eventually the fluid that's being produced by your eye, it actually goes back into your normal sort of vascular system. Gets recirculated through your body, and then your eye makes more fluid. So here's that sort of this broad arrow demonstrates the fluid being made by the back of your eye, this structure called the ciliary body, coming out around the lens, coming out around the iris, and eventually making its way out the drainage pathway here. This is where most of the fluid is drained. Okay, so that would be an open angle. Now, what would a narrow angle look like? And this is the differentiation between these two types, these two major classifications of glaucoma. So an open versus, say, a narrow or closed angle. Well, here's an open angle, and this is another cartoon in which the fluid is being shown, being produced in the back of the eye, coming out around the lens, and having easy access to the trabecular meshwork and to leave the eye. Now, here's an example in which the angle is closed. So here, everything's sort of pushed forward, as you can see in this cutout cartoon. The iris is sort of bowed forward, as we say. The fluid being produced here, you could imagine, might have a hard time getting out. And that is what we call a closed angle or a narrow angle. Now, having said that, people can still have a higher than normal pressure with an open angle. Just because the angle looks open doesn't always mean that the pressure is low enough for your eye. But it does differentiate how we start the treatment. And let me show you what that looks like. So here's how we examine that. You've probably seen us do this. We place this sort of prism on the eye during your slit lamp examination, and we look at the angle. We may do that just once every year, or sometimes more often, or sometimes less, depending on what we're looking for. But again, it helps us knowing what type of glaucoma you have and where to go with the treatment from there. So this prism allows us, because you can't see the angle just at the normal slit lamp, the prism allows us to see by sort of, there's a little mirror, and we can see into that little corner right here. There's other ways to evaluate the angle that are sort of tests that aren't normally done routinely, but there are new machines come along that may be helpful for us to see the angle in certain patients. One's called the anterior segment OCT. These machines are often found, they can be found in doctors' offices, but often they're found at an institution here like Wills where we have specialized testing. And looking at this machine, it's helpful because it can determine whether or not the angle's open or closed without having to put that prism on a person. Most people, I'll be honest, can tolerate the prism on their eye. I've had maybe one or two people who just are very difficult to examine, and I've placed them at this machine to determine if their angle is closed or open. And here's an example of a person who has a somewhat narrow angle, but whose angle is still open. And you can see that sort of this little, right in the corner, they have this little illustration of what sort of the angle degree is here and here on the eye. That's the lights on and the lights off. And a person with a narrow angle, with the lights off and the pupil dilates, the angle can become more narrow. So in this individual in whom I was concerned about, with the lights on or the lights off, it really didn't seem to matter, and their angle didn't really occlude. So this person, it was felt safe, could be just watched and observed without any further therapy. Anyway, that's called the anterior segment OCT. Another way to look at the angle is a device called a UBM, and this is a study and test that most of you folks will probably not experience, but that's actually an ultrasonic probe that's used to evaluate the angle. So we have different ways to look at it other than just the typical slit lamp gonioscopy lens that I was showing you a moment ago. This will be an example of a closed angle on a UBM. So we have again, these two sort of types of glaucoma, open angle and closed angle. Now I'm going to narrow in on the closed angle or narrow angle. There are risk factors to have this particular type of glaucoma, and those risk factors are the following. Folks of Asian descent are much more at risk of that. In fact, in Asia, narrow angle glaucoma, closed angle glaucoma is more common than open angle glaucoma, in China particularly. Women, it's 3 times more common than men. It's more common in folks who are farsighted or hyperopes. There are certain medications that people may be on that cause dilation. Folks that have a narrow angle are at risk for further angle closure with some of those types of medications. They can include things like Benadryl, which is a commonly used medicine, sort of some allergy medicines. They can include various types of psychiatric medicines that people take for anxiety or depression. So there are medicines, and oftentimes people will ask me, is this medicine safe for me? Well, oftentimes those questions really relate to the type of glaucoma you have. So many medicines will have a package insert say, tell your doctor if you have, glaucoma. Well, it's really referring mostly to angle closure glaucoma. So there are angle closure subtypes. There can be folks that have an acute attack of angle closure, or there could be folks that have more of a chronic course. Okay? An acute attack is a very significant and very serious condition. That's a sudden closure of the drainage angle, and you have an immediate, severe elevation of the intraocular pressure. Signs and symptoms of this include eye pain, nausea, blurry vision, headache, tearing, like halos around lights. And patients who have this often present to a local ER because they're in such pain. These are not common things. Most of you folks will never experience this, thankfully. But we do see these. I see several of these, but at least several a year that I have to break with a laser. It's a true emergency, like I say. Probably more common than that is more of a chronic angle closure glaucoma. But both of them will have a similar way of treatment, and that's with a laser I'll get into in a moment. Intermittent angle closure attacks may have milder symptoms. So you can have people who may be having attacks here and there, but have somewhat milder symptoms. But again, chronic angle closure is generally asymptomatic. These folks don't know that they're having angle closure. They don't present to the ER with headaches and blurred vision and that type of thing. Angle closure glaucoma in the U.S. represents about 10% of the glaucomas in the U.S. So it is the minority here, but it's still a significant number. And as I said before, it is much more common in Asia. What is the treatment of an angle closure attack, or even the initial treatment for chronic angle closure glaucoma? It's something called a laser peripheral iridotomy, or an LPI. And here's another cartoon. These cartoons are always helpful. And basically here it shows an individual who may be an angle closure. See here the fluid is sort of trapped, so to speak, behind the iris. The iris is kind of bowed forward, and the angle is being occluded or blocked. So the fluid just can't get out. And you can imagine in this situation the pressure would be higher than normal. Well, what's done is a laser is used to make a tiny hole in the iris, a hole that you really can't see in your day-to-day sort of activities. And a friend or a family member can't really look at you and say, I see this hole. But this hole is made in the iris, and what that does, it allows the iris to kind of go back to its normal configuration. It can open up the drain again. It could break an attack, or in some cases can prevent the eventual development of angle closure glaucoma in a person who's at risk for this. So here's how it may look on like a slit lamp photo, this little dark hole in the iris. But generally it's not even this noticeable. So a laser peripheral iridotomy is the treatment for angle closure glaucoma, the starting treatment for angle closure glaucoma. Risks of the laser can include blurry vision, elevated intraocular pressure, inflammation, or visual distortion, but generally it's a pretty well-tolerated, quick, and painless, and fairly painless procedure. So as I said before, a laser peripheral iridotomy, or an LPI, can prevent glaucoma in an individual with a narrow angle, but it does not cure glaucoma if optic nerve damage has already occurred. For that, you still may need drops and or surgery. So if an individual has a narrow angle, we may do the laser. We may do the laser to prevent a development of glaucoma if the pressure hasn't started to rise yet. But if an individual has had a narrow angle, is starting to have damage to the optic nerve, that damage may still need to be treated. You may still need to keep a still lower pressure with drops and or surgery. So the difference between open angle glaucoma, again, and sort of closed angle or narrow angle glaucoma, is really generally is in the initial therapy. Now let's move forward a little bit. There is another type of laser which is not done quite as commonly, but frankly I think some neat videos are always in order here. And this is a procedure in which it's called an iridoplasty, similar to the iridotomy. It's in which the iris is almost sort of compacted, and that can help open up the drain too. And let's see if this will run. So that's done in the office, and that's done in an individual in whom the laser iridotomy was done, and the angle still looks kind of narrow, and you think, well, maybe if I do a little different laser technique, I can help open up the drain a little bit more. So this sort of compacting laser is done that sort of pushes the iris back. You can see that that iris tissue kind of shrinking as the laser is applied to it. See that? It's pretty neat. So that can be helpful. But I don't do a ton of these because this may regress. It's not done nearly as commonly as a laser iridotomy. The most common situation in which this laser is done is called something called plateau iris syndrome, which is a rare sort of subset of angle closure glaucoma, seen probably in less than 10% of people who have narrow angles. They may have this condition called plateau iris syndrome, in which they remain narrow even after a laser iridotomy. Now let's talk a little bit about, let's sort of shift gears and talk about other types of glaucoma. I'm still sort of in the angle closure subtype. And again, I want to use that as sort of the divide and fulcrum between these two types of glaucoma, sort of narrow angle and open angle. And sort of looking again at the angle closure subtype, we have this condition called neovascular glaucoma. And this condition is a type of glaucoma that I do see now and then, and this is one that oftentimes comes again as sort of an emergency with high pressures. And these are folks who have a type of glaucoma secondary to other medical conditions, typically diabetes or some other eye problem. So it's seen in a condition in which folks have retinal ischemia, meaning that they're not getting enough blood to the back of the eye. Diabetic retinopathy and retinal vascular occlusion are the two most common causes of retinal ischemia. And what I see on my end is people are sent to me because they have elevation of the intraocular pressure due to the growth of abnormal blood vessels over that trabecular meshwork that I showed you in that cartoon. So diabetic retinopathy can look like this. It can look like sort of dilated blood vessels and sort of hemorrhages in the back of the eye. If untreated, diabetic retinopathy can lead to a situation where you have retinal ischemia and the eye's not getting enough blood, the retina's not getting enough blood. There's a stimulus from the eye to grow these new blood vessels, but they're abnormal. They're frilly and they tend to bleed, and it's not a healthy type of blood vessel. Sometimes those blood vessels will even grow into the front of the eye, the anterior segment of the eye. I'll just go back for a moment. That's what I've shown you here. Here's a person who has blood vessels growing even onto the iris, which is not a normal place to have blood vessels growing of this caliber. So here it is in the back of the eye, what it looks like initially. You have these sort of frilly blood vessels growing near the optic nerve, and again, they can grow in other parts of the eye and cause higher pressure. And here it is sort of growing into the angle, covering the angle of these abnormal blood vessels. As you can imagine, if you have abnormal blood vessels covering your drain in your eye, your angle, pressure is going to go up. So what's the treatment of neovascular glaucoma? Well, unlike the other types of angle closure glaucoma, it doesn't start with a laser. Really, the treatment of neovascular glaucoma, initially, if it's early enough, is suppression of this neovascular stimulus. And that's done generally by the retina specialist with injections and sometimes a laser. The glaucoma itself can be very difficult to control and often requires surgery. So now we're going to the other side of this fulcrum, this open-angle glaucoma. The most common type of open-angle glaucoma is primary open-angle glaucoma, or POAG, and that's what most of my patients have. That affects 2.25 million Americans over the age of 40, and that number is growing as our population is aging. Blacks are 3 to 4 times more likely to develop POAG than whites for various risk factors, some of which may include just the way the eye is made. Risk factors include high IOP, age, and race, and also one more, it includes a thin cornea to develop open-angle glaucoma or glaucoma in general. And one of the reasons why folks of African descent may have more open-angle glaucoma than others is because they tend to have thinner corneas. That's one of the theories. Just the way people are made, everybody's eyes may be made slightly differently. Treatment, the first-line treatment of open-angle glaucoma are either drops or a laser, but not the kind of laser that I showed you, a laser called a laser trabeculoplasty. So there is a difference in initial treatment. You don't do a laser iridotomy. The angle already looks open. It's not like you can make the angle more open, and that would necessarily be that much more helpful. This laser is called a laser trabeculoplasty if you do a laser in open-angle glaucoma, and it can reduce the intraocular pressure by improving the outflow of fluid. It sort of stimulates the drain to work better, is what I tell my patients. There are open-angle glaucoma subtypes, including Pigment Dispersion Syndrome and Pseudoexfoliation Syndrome or Pseudoexfoliative glaucoma. So again, most of the types of glaucoma that I treat is open-angle glaucoma, and most of that is something called POAG. That's the vast majority of my patients. There's some folks who have open-angle glaucoma with normal pressures. Those are called normal tension glaucoma, but they're also treated the same way. They're treated with drops or laser. Okay, and then there's these sort of subtypes that have certain particular findings that sometimes can have other things that go along with it that you may need to be aware of. And let's talk briefly about those. So Pigment Dispersion Syndrome is a subtype of open-angle glaucoma that has a few characteristic findings. One of the things you may see if you're examining a person with Pigment Dispersion Syndrome is they can have iris pigment granules on the inside of the cornea, and actually some iris pigment granules coloring the trabecular meshwork. The classic presentation is what we call transillumination defects, where the iris can actually be seen, you can actually see sort of through the iris. The light reflex shining in the slit lamp will come back at the examiner, and you can see that the iris is sort of thinned out, because what's happening is pigment is sort of being liberated or released from the back side of the iris, and it's sort of almost clogging the drain. You can think of it that way. So this is, again, a type of glaucoma. Again, the thing here that's important is gonioscopy. I get to this a lot. It is important to look at the angle. As you could tell, the angle told me a lot. It told me whether the person sitting in front of me has an open angle or a closed angle. And it can also tell me even more. It can tell me if this person with an open angle has a type of glaucoma called Pigment Dispersion Syndrome or Pigmentary Glaucoma. So here's another picture of the angle. This is called gonioscopy, when we look at the angle with that little prism. When you look at the angle of an individual with Pigment Dispersion Syndrome, you see a densely pigmented trabecular meshwork and often a concave iris. So instead of bowing forward like I showed you in that other cartoon with folks who have sort of a closed angle, the iris actually almost bows back, sort of like a deflated balloon or a parachute that's no longer sort of being used. It sort of bows back and sort of almost takes the contour of the lens that's behind it. Almost sort of, you can almost imagine the iris just kind of laying sort of flat on the lens. And we think it's because of that way it sort of bows back that it releases pigment. And this pigment being released then goes and clogs the drain. There are risk factors for this particular subset of glaucoma. It's generally seen in younger folks and more often males who are nearsighted and more often who are white. It's 1 to 1.5% of all the glaucomas in the U.S. Pigment Dispersion Syndrome, just having this condition but not necessarily having optic nerve damage, and because not all the folks who have this develop optic nerve damage, it's seen in about 2.45% of people of European descent or whites who are screened. the probability of having pigmentary, like pigment dispersion syndrome, this finding of this extra pigment in the eye, and then converting to glaucoma, was about 10% at 5 years. So if an individual is diagnosed with pigment dispersion syndrome, about 10% at 5 years they have a chance of developing glaucoma. At 15 years, they have about a 15% chance of having glaucoma. So the minority do not go on to develop glaucoma, but enough do that it's a condition I do see fairly frequently. The mean age of diagnosis of pigmentary glaucoma, it's a little bit of a younger disease. So instead of being diagnosed at an older age, like most folks with open-angle glaucoma, pigmentary glaucoma is typically diagnosed younger, in the 40s. The most significant risk factor for developing pigmentary glaucoma is having a higher pressure when you're first seen. So having a pressure higher than 21, according to this one study. And again, like I said before, being young and nearsighted and male, they seem to have more pigmentary glaucoma. What's one of the problems in pigmentary glaucoma? And I tell you this because it can be something that needs to be evaluated periodically on examination. Well, some folks with pigmentary glaucoma can have retinal detachments. So they're more prone to retinal detachments. And this is a picture of a retinal detachment. You can see here the retina is not flat the way it should be, but it's almost kind of flapping in the breeze. That's a retinal detachment. That generally needs to be operated with surgically. It needs to be fixed. What is the treatment of pigmentary glaucoma? Well, typically the treatment is drops. But sometimes a laser is used to help pigmentary glaucoma or pigment dispersion. In fact, it's the same laser that was used to treat a closed angle, a narrow angle, the LPI. Here it comes again, but it's done for a completely different reason. Instead of making the iris go from sort of a bowed anterior position to flat, like it did in a closed angle, here the idea is to make the iris go from that concave sort of flattened back, that sort of bowed back position to make it go flat, and it does the same thing. So what we do is we do that laser, and it can actually flatten out the iris, and the thought is, by doing that, it may help prevent the progression of glaucoma. But that's sort of controversial, and that's not always done. In fact, in folks that already have higher intraocular pressure, already have pigmentary glaucoma, the laser has been shown not to be helpful at all. And in some folks, it can cause an increased pressure right after you do it. Other types of glaucoma that are seen now and then are things like trauma or traumatic glaucoma. This is most frequently seen after blunt, non-penetrating trauma. Acutely, patients may have something called a hyphema. So if you have blood in the eye, you're at risk to develop glaucoma later. Okay? And that's typically a pretty hard blow to the eye. The IOP remains elevated. The intraocular pressure may remain elevated after the hyphema resolves. And you have a delayed presentation sometimes. Sometimes people will have like a unilateral glaucoma in my office. And if you really delve deep into it, they'll have this remote history of trauma in that eye. Treatment, though, after diagnosis is similar to standard open-angle glaucoma. But there's some thought that doing a laser trabeculoplasty or an SLT may not be as effective. Here's an example of a person that I saw, and here's a gonioscopic photo of basically this area where the angle is sort of damaged. And you can imagine where the angle is damaged, where the drain is damaged, it's no longer going to work well. There's sort of a tear sort of into the angle structure. The patient's pressure was high, and the optic nerve was unfortunately damaged. You can develop glaucoma or high pressure from steroids, and that's a question I get asked a lot. Will this affect my pressure? And the answer is it could. There are risk factors to develop steroid glaucoma, and those include having glaucoma or being a glaucoma suspect, include having a first-degree relative of glaucoma, being myopic, having diabetes, or connective tissue disease. The topical route, meaning drops, that's the most likely cause to have an elevation of the pressure. So long-term steroid drop use can raise your pressure. Systemic steroids are less likely to influence the intraocular pressure, but they can if they're a higher dose used for a longer period of time. There are other routes that I've seen that can affect the pressure. For instance, some folks will be using steroid creams on their eyelids for various reasons, and they keep using that. Eventually, you can raise your pressure that way. Inhaled steroids, nasal steroids, much less common, but it's been reported. There's also other ways to get it. For instance, sometimes other conditions are being treated, other eye conditions, and you're getting steroid injections in or around or into the eye, and that can raise the pressure. That's often done for various retinal disease. With topical application, with drops, if pressure is going to rise from steroids, it typically does within the first 2 to 6 weeks. The more potent the steroid, the greater the sort of effect. So if you're on sort of a mild steroid, often you don't see much of an effect. But some of the strong steroids used, that we use sometimes for various eye conditions, sometimes they're used around the time of surgery. Sometimes the strong steroids can have more of an effect. With systemic steroids, it's the length of time that they're used that sort of determines how much of an effect there is. What happens? Well, we have to stop the steroids if possible. So basically, if you've been on steroids for a long time, like drops, the steroid response typically resolves in weeks. If there's been steroids injected into the eye, they may need to be surgically removed, and steroid alternatives may need to be used. If it's irreversible and the pressure's high, it's treated just like other glaucoma. Finally, and the last thing, and you guys have been great and really stuck with me, and I hope I've gone through all these. There's other types of glaucoma, but I thought I would hit some of the key notes and the ones that some of you folks may have or heard about. The last one is called Pseudoexfoliation Syndrome. Pseudoexfoliation Syndrome is a subtype of open-angle glaucoma. It's the most common identifiable cause of secondary open-angle glaucoma, meaning you have glaucoma, you have an open-angle glaucoma, and here's why. Most of the time, with primary open-angle glaucoma, or POAG, what most of my patients have, you have glaucoma, we don't exactly know why. Maybe it's because of your family history, there's something there, but we don't exactly know why. With pseudoexfoliation syndrome, we can look at you and say, well, you have this condition called pseudoexfoliation syndrome. With pseudoexfoliation syndrome, some people develop glaucoma, and that's what it is. It's more common in Scandinavian populations, but it's found in all sorts of populations around the world. In a study out of Iceland, 40% of the individuals 80 years or older had pseudoexfoliation syndrome. That doesn't mean they all had glaucoma, but they have this syndrome which can lead to glaucoma. It is very rarely seen in individuals younger than 50. The findings here is this sort of deposition of this white kind of fluffy material on the anterior lens capsule. And you can see this circle. I hope it's showing up here. This circle on the lens capsule right here. This is this white sort of, we call it fibrillar material, that we think actually what it does is this material and maybe a mild inflammatory state, but what it does is that the trabecular meshwork of the drain sort of slowly becomes clogged or dysfunctional. You have this central clear zone. You have this little ring here. And then oftentimes you'll see a second ring right out here. And you'll also sometimes see that material right on the pupillary border. So we can see this material during the exam. It does have some issues that can come to play. For instance, pseudoexfoliation syndrome, the glaucoma can sometimes be notable for pressures that are more what I call labile, meaning they're up and they're down. Typically, though, it's treated just like any other type of open-angle glaucoma. But cataract surgery in folks with pseudoexfoliation syndrome can be complicated by loose zonules in some cases, meaning the cataract may be more difficult. It generally isn't, but it can be. Also, one thing we see now and then is after cataract surgery has been completed, maybe even years down the road, you can get a delayed, what's called an in-the-bag dislocation of the intraocular lens. So the intraocular lens, here it is sort of dislocated. It can actually sort of sink down because the whole support system of the cataract and afterwards the artificial lens can be loose because of the pseudoexfoliation syndrome. That's nothing that you need to do differently, but it is something the surgeon who may be operating on you, if you have this condition, they should know before they do your cataract surgery that this condition may be present. It may change the approach they take for your cataract surgery. So in summary, glaucoma is an optic neuropathy characterized by the loss of a specific type of cell body called the retinal ganglion cell. It is notable that glaucomas from IOP, IOP that is too high for a particular individual is the single most important risk factor and the only modifiable risk factor for glaucoma development and progression. Glaucoma can be divided into open and closed angles with these many subtypes that I showed you. And finally, treatment of glaucoma is with drops, lasers, or surgery, depending on the individual. Thank you.